Good morning, everyone, and thank you for joining us. My name is Jennifer Larson, and I'm the training coordinator for the Office of Community Living. I will draw your attention to the slide just to point out some of our webinar procedures. We are recording today's session, so just be aware of that, and we will be making it available on our website in the coming days. We will be using the chat panel primarily to manage your questions, so please type those in as you have them. You can also get a copy of today's slides. They are available for you in the Files panel, which is just below the chat box for you to click and download. And we will make those available on our website as well after the training. With that, I will go ahead and turn it over to Michelle to start the presentation.
Thank you, Jen. This is Michelle Craig. Can you hear me?
Yes.
Okay, good. Always good to do the sound check. So good morning, everyone. Thank you for taking some time to join us this morning for the CHRP provider training. And thank you, Jen, for going over kind of the intro and basics for the presentation. And I apologize if this is repetitive. I may have been tuned out for a slight second. That the presentation is available for you all to download. It's in the Files little pod on the webinar screen. So before we jump in, I would like to also introduce my colleagues who are on the call, Kathleen Holman and Nancy Harris. So starting with Kathleen, do you want to unmute and say hello? Kathleen, if you're talking, we can't hear you.
Hi, sorry, can you hear me?
Yes, we can.
Oh, sorry. This is Kathleen Holman. Hi, nice to see everyone. Some familiar faces out in the crowd. I am the CHRP waiver development specialist. I've been working with Michelle and Nancy on this team since early May, and I am very happy to transition into this position from my benefits specialist position here at the department. I've been with the department about 3 years, so thank you, everyone.
Thanks, Kathleen. Nancy, are you on, and do you want to say hello?
Hi, I am on. Can you hear me?
Yes, we can.
Okay, somehow I didn't get the actual webinar, so I don't have access to that, which I just asked Jen to forward to me. But I am online, obviously, with phone. So glad all of you could participate, and hopefully it will be a really learning experience for everyone, and asking questions is just a great thing to do, which we really appreciate, and so I'm looking forward to that. Thank you.
Wonderful. Thank you, Nancy. So again, this is Michelle Craig with Healthcare Policy and Financing, and my role here at HCPF is a section manager that works with our nursing facilities, regional centers, our PACE organizations, as well as a unit that's working on improving access to services for children and adults with disabilities and who also have behavioral or mental health support needs, which is what has been part of my CHRP work for the last couple of years on expanding and enhancing that waiver. Okay, so with that, I think we will move forward. So our agenda today, what I just want to go through and let you know what we're going to cover today is this is a training specifically targeted for existing providers of the Children's Habilitation Residential Program, or CHRP waiver, as well as any potential providers who are considering becoming a CHRP provider. So like Nancy said, we really want to use it as an opportunity to talk with you about some of the requirements, what the CHRP waiver is all about, hear some questions and feedback from you all, and then we'll sorry, I can't watch the chat and talk at the same time. I need to do better. It's like, oh, I can't watch both. But for the questions piece, what we kind of plan to do is at the end of each section, we'll pause and go through the questions in the chat box. If anybody needs to, on the phone, unmute, we can have that option too, where you can unmute and ask your question or comment over the phone. So we'll do that, excuse me, at the end of each section. So if we don't immediately respond to your chat question, give us a few minutes. We'll try to wrap those up at the end of each section. And excuse me, of course, once I start talking, then my voice starts to get a little raspy. So we are going to go over a little bit of the background, kind of high level with the CHRP waiver, where we were a couple years ago when we started this work and where we're at now. We're going to talk about the eligibility and enrollment requirements for the waiver, the case management requirements for the waiver. Then we'll get into what services are offered by the waiver, and as part of that, what the provider qualifications are for each service. We'll briefly go over the regulations. Don't worry, I'm not going to go through each regulation for you, but we'll point to with some of the uniqueness about the CHRP regulations that some people may not be familiar with and where to find those. We'll talk about provider capacity. We have grown significantly in our capacity for CHRP over the last year, but we're still really in need of additional providers. Then we're going to talk about some progress and improvements that we've made, particularly over the last year with the waiver, and then what our plans are moving forward with evaluating the effectiveness of our changing and of our changes, and then ongoing efforts to continue to improve services. And then we'll wrap it up again at the end for another chance for questions and comments. So background, I'm looking at a lot of the names on the attendee list, and a lot of you may be familiar with this, and some people may not. So the background with the CHRP waiver is that prior to July 1st of 2019, the waiver, the eligibility for the waiver was really only for children with intellectual and developmental disabilities, complex needs, who were in child welfare. The waiver had historically been managed by the Colorado Department of Human Services, and case management had been done at the local county departments of human services. So in order to increase or expand this waiver to more children and families who could benefit for us, we implemented some changes just a year ago. It's hard to believe that it's been a year, but we expanded the eligibility to include children with intellectual and developmental disabilities, IDD, who have complex support needs, and we'll get into what complex support needs are in a minute, who are not in child welfare. So now the waiver can serve both children who meet that criteria who are in child welfare and children who are not in child welfare. We transferred the case management for the waiver from the counties to the community-centered boards, or CCBs. We added 2 new services that we'll talk about a little later in the presentation, intensive support and transition support, really in an effort to support children to remain in the family home or to transition back to the family home after out-of-home placement or to a lower level of care. And then the official administration of the waiver was transferred to healthcare policy and financing. All right, I'll pause just to see. I saw some chats come in about some technical issues, but I think we're good. So I'll keep going unless Jen, we need to stop or do something different. Okay, so getting into eligibility and enrollment. So the eligibility for this waiver is children and youth ages birth 0 through 20, determined to meet developmental delay or disability criteria. They must meet the ICF, IDD, Intermediate Care Facility criteria, and they have extraordinary needs that put them at risk of or in need of out-of-home placement. Further defining those extraordinary needs, we break them down into 2 categories. One is complex behavior supports and one is complex medical supports. So the complex behavior supports are needs that must be related to a diagnosis by a licensed physician, psychiatrist, or psychologist. Now, sometimes, if some of you worked with some of our other waivers or worked with people with intellectual and developmental disabilities in the mental health arena, I think we can get a little nervous about the diagnosis. This doesn't necessarily have to be a mental health diagnosis, although likely it will. It just needs to be some type of medical or psychiatric diagnosis that results in the child having extraordinary behavior support needs that really put them beyond the control of their parent, put them beyond the control of the participant themselves. And then complex medical support needs or needs that occur as a result of a chronic medical condition that has lasted or is expected to last 12 months, requires skilled care, and without intervention may result in a severely life-altering condition. Quick background on this, just for any of you who may not have been involved from the beginning with our efforts to expand the CHRP waiver. We conducted a significant amount of stakeholder engagement and really worked with advocates, family members, some service providers, CPAs, and other folks to really hone in on these definitions. And so these were developed with a lot of stakeholder impact or feedback. Sorry, I moved ahead on accident. A couple other things about this. Some of you may work with the Children's Extensive Supports Waiver where there is an application. For CHRP, there is not an application. It's really the community-centered board is the agency that will conduct the assessment, if you will, and determine if a child is eligible for CHRP. So they will go through and look for all that information, work with the family to get the information, and then once they have all that information, they make the determination if the child is eligible for the waiver. For the extraordinary needs, the only thing we need from that is some type of documentation. So that we've said that it could be the physician's medical information page, the PMIP. It could be, a letter from a doctor or a psychologist, just some type of actual documentation signed off by that licensed professional that due to a medical or psychiatric diagnosis, the child has one of these or sometimes both of these support needs. So before we move on to financial eligibility, I will pause and see, do we have any questions in the chat box regarding this portion of eligibility? Okay, so
we have one from Kelly.
Yep, I got it. Thank you. So from Kelly, we have, what if the chronic medical condition is expected to be permanent or longer than 12 months? Will that qualify as a complex medical support need? Yes, Kelly. So it has to last at least 12 months, but if it's ongoing, that will still meet the qualification. Okay, see a couple other people typing. Technical issues, of course, as with all the challenges we're all facing, right, living in this virtual world, but we'll continue to work on those. Okay, Nancy or Kathleen, anything that you wanted to add for this portion of the eligibility that I may have missed?
No, not on my end.
No, I have nothing else to add either, Michelle. Thank you.
Okay, great. Thank you. Kathleen and Nancy, I will make it a point to stop and ask, but as you know, I think probably even Nancy has done more of these webinars with me that I can continue to roll on, so please interject if I miss something. So financial eligibility is pretty straightforward. It's the same eligibility requirements that we have for our Children's Extensive Supports Waiver. We do not consider the parents' income for Medicaid financial eligibility. Social Security income or SSI is not required. However, the child will need the SSI disability determination or ARBOR application in order to qualify for the waiver. Also, if the child or youth is receiving habilitation services and that is 24-hour out-of-home placement, they will need an income source to pay that provider room and board. So at that point, they would likely need to apply for the SSI financial eligibility. Okay, I'm going to pause. I saw a question come through from Terry. How many children 0 to 21 are currently enrolled in the program, and what are the projected growth trends? That's a great question, Terry, and we get that a lot. Starting this project, we had the numbers for CHRP were actually had dropped pretty low, in fact so low that we weren't able to say what the number was because of safe harbor rules. But now I think we're about 97 active PARs in the system, which is really huge growth. That was a tad over what we projected for the year, which I think we had projected for the first year about 87, and then maybe a little bit more into the 90s for the second waiver year. It was very difficult for us to do projections because a lot of our projections are based on historic utilization. And because the population had been so limited, we just didn't necessarily have a good idea of how many kids out there were going to need this waiver, what services they're going to want until we rolled it out. So we're actively monitoring the information and talking with CCBs about how many more children or youth they've identified who might need this or might need to transfer to CHRP from CES. And so I think what we're thinking for this next year is likely not the dramatic growth spike that we saw the first year of the waiver changes, but maybe 30 to 40. We're still trying to hone in on that, and the next year too will help us probably get a really good idea of future growth. All right. Well, I'll answer this quick question from Yulia. I apologize if I'm not pronouncing your name correctly. The question is, hello, how can we apply to waiver to become a provider? And we will get to that towards the end of the presentation. I should have said that at the outset. When we get to that provider capacity section, we'll talk about steps to become a waiver provider and steps to become a CHRP provider. Okay, the other portion that's needed, this isn't so much needed for eligibility, but really for the support level. So for CHRP, for the residential habilitation service, which again is a 24-hour out-of-home placement, we do have 6 support levels. Support levels 1 through 6, 1 being the lowest reimbursement, 6 being the highest reimbursement. And those levels are determined by the ICAP assessment. So ICAP stands for Inventory for Client and Agency Planning. If you're interested, I mean, this is done by the case managers. We train the case managers at the CCBs to do this assessment. But if you're interested in learning more about it, there's a link to the training we have posted on our website. Again, this support level is only used for the habilitation service. Every other service in the CHRP waiver has a set fee for service or set just one reimbursement rate. Again, the CCBs do the ICAP, and we do reimburse the CCBs for conducting the ICAP through their administrative contract. In completion of the ICAP assessment, the respondents can be people who have known the child or youth for at least 3 months and sees them on a daily basis. We have a little bit more flexibility with the ICAP than we do with the SIS. So any of you familiar with the Developmental Disabilities DD waiver or Supported Living Services SLS waiver, excuse me, that assessment is a little bit different. With the ICAP, excuse me, we suggest that the case manager and team review the ICAP at least annually, mainly because you've got, kids who are growing into youth, who are going through puberty, who are starting to enter early adulthood, and so needs change. And so we really have given the CCBs flexibility to review that assessment at least annually or as often as they need to, and conduct a new assessment when they feel that it's necessary. They don't have to reach out to Healthcare Policy and Financing to request that a new assessment is done. They can do that when the team feels that has become necessary. If you're interested, oh, I'm sorry, I skipped ahead a little bit. The other thing that we have available is we do have a support level review process, understanding that while, we think we have a decent tool, it may not always capture every need. And kids and youth are different. I mean, people write things come up that are different. So what the support level review process, if you're interested, can be found at the link on this slide on our memo series page on our website. But essentially, the reimbursement levels for residential services, I said, are 1 through 6. 1 through 5 actually are all that the ICAP will score out to or equate to. If a child scores to a level 5, but that's still not going to be high enough to meet the child's need, then the case management agency, the case manager, can submit a support level request to Healthcare Policy and Financing to request a level 6. The level 6 is not a negotiated rate. It's a set rate, but it is a little bit higher than the level 5. The agency can also send a request, so maybe the child, their support level score equaled out to, or their ICAP score equaled out to a support level 2, but the team really feels like it's not reflective of the child's needs. They do another assessment, still the scoring's the same. They can submit that request to the department, to Healthcare Policy and Financing, to request a higher support level. And then Nancy Harris is our expert on the ICAP, and Kathleen and I and other members of our team support her as necessary to review those requests and make those decisions. So maybe a support level 4 will be approved. But that's the process for there. Again, won't spend a lot of time on that, but please look at that operational memo if that's something that you're interested in. There's a question from Sarah. I've heard that the CCB needs special approval to designate children at a level 6. Is that accurate? Yes. And you may have typed that while I was talking, so I'll just reiterate that real quick. The scores for the ICAP will equal out to either a support level 1 through 5. For that support level 6, this case management agency needs to make a request to the department. And then Terry asked where the ICAP support level reimbursement found. I'm just assuming what the rates are. We'll get to that here in a couple of slides, but it's on our fee schedule for the CHRP waiver, which is posted on our website, and we will have a link to that here in a few slides. All right, Nancy or Kathleen, anything you want to add about the ICAP?
No, not at this time. Thanks, Michelle.
All right. Okay, so we will move on. Actually, I'm going to pause. I have one more thing that I want to mention on here. This applies to a very small number of kids, and this is really more of a case management technical detail, but it applies here, I think. So sometimes we do have youth who have to seek placement out of state because their needs are so high we just can't find a provider in state. When they do that, the goal then is to obviously, once they've had, followed a treatment program or whatever it is, maybe get some stabilization, that they return to the state, either more than likely still with an out-of-home placement out of state, but then hopefully back to the family home at some point if that is what's best for everybody. So understanding that when the child is ready to come back in state, they are going to need services day one, right? They're going to be able to come back and wait for eligibility assessments to be done, ICAPs to be done, then find a provider, then do this. Like, they're going to need a place to live day one when they come back. So this is even pre-COVID, and we will continue this after COVID, but we do allow for CHRP for the case management agency to conduct the 100.2 virtually, and we allow them to conduct the ICAP assessment virtually. And then we ask that they that's the wrong word, they find the people at the out-of-state provider agency as best they can who've been working with the child. They may not have known them for 3 months, so we allow a little bit of flexibility there, but they get the staff who are working there, the clinicians who have been working with the child to be respondents, as well as, parents or family or other people in state who know the child. And then once the child comes back into state, then we ask that they do the in-person just do an in-person review of the ICAP and the 100.2 as soon as they're able within the first couple of days. Now, I understand with COVID, that's not the practice right now, so that would still be virtual, but we do allow that flexibility because we have had situations, that exact situation where kids have needed to come back to the state and have a provider, the minute they cross the border. All right. All right. Terry, we'll just Terry's question really quick. Terry's question is, are most of the children in a RCCF, which is a residential child care facility, or are they in a treatment foster care setting? It's actually a variety. We do have a few children who receive services in the RCCF setting. I would say that for those children receiving habilitation services, the majority of them are using a foster care home setting, and when we get into habilitation services and talk about provider types, we'll delve into that a little bit more and what the different residential type placements are. And Gabrielle, I think when you talk about placement and referring them to be put in a group home or host home, we'll get to that a little bit more detail in a few slides when we talk about habilitation. So case management for the waiver. So basically, it's targeted case management. It's the same case management that's provided for individuals who utilize the developmental disabilities waiver, the supported living services waiver, and the children's extensive support waiver. Same requirements. It's a state plan benefit, has the same components. The case manager does, the eligibility, the 100.2 assessment, the ICAP. They do referral for service. They do service planning, and then they have the quarterly monitoring. And it does say face-to-face on here because that's in the pre-COVID world what it is. I do realize that that's virtual. So right now, obviously, we do allow for that virtual quarterly monitoring. And Cindy put a question in there about RCCF rates, and we will get to that when we get to the habilitation slide. The other point I wanted to get into about case management, because this isn't a case management training, and just so you know, we've done significant training and technical assistance with the case management agencies for the last over a year. We've held monthly TA calls with them. We've done specific case management trainings to help them learn and understand the waiver. One thing that I want to make sure everybody's aware of is that conflict-free case management does apply to the CHRP waiver. So prior to us moving case management to the community-centered boards, as I said, the case management used to be done by the counties. So for the most part, case management was done by the counties, and then child placement agencies or like a residential child care facility, those agencies were the provider. So we really didn't have any conflict. For anybody who's not familiar with what conflict-free case management means, it's essentially that the same agency may not provide case management and waiver services to the same child and youth. So historically, we've pretty much not had that issue in the CHRP waiver. When we moved case management over to the CCBs, our federal partners, the Centers for Medicare and Medicaid Services, told us, you can't take a waiver that's not in conflict and put it into conflict. So what that means is the community center boards, who most of them also have a service provider arm, the community center boards are not allowed to provide case management and CHRP waiver services to the same CHRP waiver participant. So in some of the more metro or urban areas, that's a little bit easier because we have more CHRP providers. We have CCBs who are a little closer together, who maybe, if for example, if one agency wants developmental pathways to be its provider, but they live in Aurora, maybe Rocky Mountain Human Services could be the case management agency. That's very individualized. Where we see a little bit more of a problem is in our rural areas, where really the CCB is really the only provider for any type of IDD supports. So we're continuing to monitor that, continuing to work with providers across the state about expansion. And towards the end of the slides I'd mentioned, we're going to talk about provider capacity. So I'll just put a plug in now for y'all to be thinking that if any of you do operate in more rural areas, maybe you haven't historically done intellectual developmental services or CHRP, but if you would be interested in maybe expanding, particularly in some of those more rural areas. So we will come back to them. Okay. Any questions? Let's take a couple questions in the chat box that we'll get to in the next couple slides. Any questions about case management, or Kathleen or Nancy, if you want to jump in with anything?
I don't have anything at this time.
I don't either, Michelle.
Okay. Well, I just realized I skipped ahead myself too, because we have a couple more case management slides. I'm trying to have a side PowerPoint as I can keep where I'm going in the future, then the one we're showing you guys. So wanted to talk a little bit about change in case management agency. So with CHRP, and this can be whether the child is in child welfare or not in child welfare, it can be difficult sometimes to find a good residential fit for a child who needs out-of-home placement, particularly maybe if they're in a rural area. So we do see from time to time that children or youth will need to seek out-of-home placement in an RCCF or foster care home or group home or group facility outside of their district or, county of origin. So, for example, we could have a child living in, I always use Larimer County because Larimer County is where I'm from, so we could have a child living in Larimer County, can't find any, really anything in the vicinity, but found a really great foster care home in Aurora. Like, this family's got great experience, this is going to be the best place for the child, and so then the child is going to go to that out-of-home placement in Aurora. So for Aurora, our Community Center Board Case Management Agency is Developmental Pathways. So at that point, the Larimer County Case Management Agency, which is Foothills Gateway, would want to coordinate with Developmental Pathways to determine when it's best to transition case management from Foothills Gateway to Developmental Pathways. If what we've said is that it's really an individualized decision with the child, youth, their support team, and people around them, but if it looks like it's going to be a longer-term placement, it probably makes sense for Developmental Pathways to take over case management because they're there and they're closer. So that can be requested by the youth and their family to change the CCB, Case Management Agency, when they move out of county, and the Community Center Board Case Management Agency cannot say no to that request. Now, I don't have a lot of information about this for today's training. It's something we're still looking at, but essentially, when a child goes to an out-of-county placement, if you will, there are some questions and challenges around school district responsibility when the child isn't in child welfare. Pardon me, that we're still trying to work through and understand a little bit better. Obviously, that's not healthcare policy and financing, that's the Department of Education, but we're trying to work through that because we have had some, have heard of some situations where there was confusion over which school district would maybe pay transportation, who does what. I don't really know where things are at with virtual learning and where things have been due to COVID, but those are some issues that we're continuing to try to explore with our partners at the Department of Ed. One quick thing to note, and this is probably more relevant for a case manager, but just so you all know, if a change in CCB is requested because a child is moving out of county, the new CCB does not need to do a new ICAP, they don't need to do a new 100.2, or need to do a new service plan unless they need to revise the service plan and add services. All right, transition to adult services. So children may choose to, or children can choose to leave the CHRP waiver at any time, right? We have a system about choice in services, and people need to, should access the services they want and are the best fit for them. But many of you maybe who work with our Children's Extensive Services, CES waiver, that waiver ends at age 18. And they have to then leave the waiver at age 18. So for CHRP, we do have a transition period. So it's anywhere from age 18 to 20. When the youth turns 21, they do have to leave the waiver at that point. What we really encourage here is with that transition period that there's really no rush. Like the youth can choose to transition to whatever other services they're going to use in their adulthood, or maybe no services, at a time when it's convenient for, not convenient, well, that too, but a time that's good for them in their life and when they're ready to make that change. Typically, we will likely see the majority of participants transition into the DD waiver, and the DD waiver does have reserved capacity for participants of the CHRP waiver. But the youth could also just choose other services that best meet their need, or like I said, maybe none. Our main point here is that it's really just meant to be individualized when it's in that youth's best interest. Okay, the intersection of child welfare. So as I mentioned, the waiver no longer requires that the youth be in child welfare, but we still may have children who are in child welfare who meet the requirements for the CHRP waiver who will be CHRP participants. So in that case, we've got, child welfare involvement with the county caseworker, and we've got CCBs. What we suggest is that in this situation that all parties really work together with strong communication, making sure all the right people are at the table, particularly that the case management agency and the county have, kind of work in lockstep, maybe if possible to do visits together. When they're done virtually, I think that's a little bit more difficult, obviously, but the involvement of child welfare does not mitigate or change any of the requirements of the case manager at the community center board. We have had some questions about who's the decision maker for children and youth who are in child welfare. Things like who signs off on a rights modification, who consents to a medication, who do we explain rights to, all those different things. Each situation may be a little different, so our direction is that consult with the county caseworker to identify who the decision maker is for the child or youth. And you probably will need to have an understanding of that for each separate type of definition. I am definitely not a child welfare expert, but I understand that there are some nuances to different types of decisions that are being made, particularly maybe some rights that the parents maintain to make decisions around medications. So again, consult with the county caseworker to identify the decision maker. And any suspected or alleged abuse must be reported to Child Protective Services. Those situations will also need to be reported to Healthcare Policy and Financing through our critical incident reporting requirements. And we have a little bit more on that, I think, when we get to a future slide on rules and regulations. Okay, so before I move on to digging into the services, I'm going to pause and see if what we need to do in the chat box. Okay, so I think the next one we need to, I think Kelly asked about wraparound and that being distinct from case management. Yep, we will get into that here in a couple slides when we talk about those services. And then Terry wrote a question, is it expected that the therapeutic and medical costs for child enrolled in program to be reimbursed only through Health First Colorado, Medicaid, or can private insurance of the parent or guardian be used to provide services? Terry, the answer is yeah, there can be a combination of both. So I think it's that typical hierarchy, like private insurance would pay first and then Health First Colorado for those therapeutic and medical costs. Which Kathleen also addressed in the chat box. Thank you. I think it's good just to read it out loud too, just in case we have people who have called in only or maybe for any other reason maybe need it read out loud. There's a question from Sandra. With respect to sibling groups, can a home serve more than one CHRP youth to prevent separating siblings? Specifically, my question is how many in one home? And Sandra, we will get to that in I think 2 slides when we talk about habilitation. Kristen had a question, what benefits are gained from a client going to CHRP instead of going from a children's waiver directly to an adult waiver? I think that CHRP is a children's waiver. So it basically, it's a choice essentially among our children's waiver. So if a family has identified that they'd like to access a waiver, they would go to their case management agency first, whether it's a CCB or single entry point. For CHRP and CES, it has to be the or the community-centered board, and then talk through what their needs are, and then look at the different services offered in each waiver, and then try to determine what waiver meets their need. If they're doing fine in the CES waiver up until age 18 and they want to transfer to the DD waiver, they can do that. There really probably wouldn't be any need at age 18 to transition to the CHRP waiver from CES. However, I think it's just more of an individualized situation about what services are going to be most beneficial. We'll get into our new wraparound service here in a minute. We only offer that service in the CHRP waiver, so that might be one of the things that is distinct, and why someone would choose the CHRP waiver is because they want to continue to use wraparound through that 18 to 20 period before they transition to the adult waiver. Maybe they want to continue to use movement therapy, could be some things like that. We are also actually working on a comparison chart between the CES waiver and the CHRP waiver. That really kind of helps get at that point, because we have had that question a lot, like how do I know what waiver I want from families, kind of what makes most sense for us, and then from case management, how do we help explain the differences in each waiver to families. So we have those comparison charts being finalized as we speak, and hope to have those out, sent out to stakeholders probably around the beginning of September. And we'll send that out through our constant contact list and post on our website as well. Okay, I think I got everything there. There looks like there was another question about number of people who can live in one household. We'll get to that in just 1 second, Jenna. Okay, we are ready to jump into services. Kathleen or Nancy, anything else before we jump into services?
Hi, Michelle. I think it's we just scanned past the decision-making slide pretty quickly, so just to show it on screen for a couple more seconds, even though people will get it in the slides.
Thank you. Okay, we're going to move into services, which I think are going to get at the last couple of questions we saw come in the chat box about serving adults and kids, and then and using CHRP without wraparound. So we have the following services available in the CHRP waiver. A family can choose one or several of these services based on what their needs are. So this is really, it's like a menu if you think about it. You don't have to have one to get the other. You can just choose what makes sense. And that can evolve and change over time as a child grows. Particularly, we hear a lot of children grow through puberty, needs change, which is the same for most teenagers, right? And families can move between these services as it makes sense for them. So the services are, one, habilitation, which is a 24-hour out-of-home residential. There is respite. Respite is for the primary relief of the caregiver. We'll get into that in a little bit more detail. Supported community connections, massage therapy, hippotherapy, movement therapy, and then intensive support and transition support. So we have some, in some cases, a couple slides for each of these services. We're going to delve into these a little bit more as we progress through the PowerPoint. First, I'd like to point out, and I know Kathleen put the link to the CHRP rate sheet in the chat box. There's a link in the PowerPoint too that you could see the rates for all these services. And then there's also a link to the CHRP waiver document itself that has the full list of provider qualifications, because obviously that'd be quite a lot to put in these slides. All right, so moving into habilitation. So habilitation is 24-hour residential out-of-home placement. And I think placement's always not there. Maybe the out-of-home residential setting maybe is a better word. I think we have a little bit of crossover with child welfare, and that placement language comes in there. So we're going to get into what those placement or residential types are in the next slide. But for this slide, I want to talk a little bit about what needs to be provided during those 24-hour supports. So a lot of it is, right, like supervision and support to get through life, day to day. If there's anyone on who provides residential services in the developmental disabilities waiver, we refined the definition of habilitation in CHRP to match that in the DD waiver. So really it's that in this residential living environment, the child is receiving supports with independent living training as much as makes sense for them, self-advocacy training, cognitive services, emergency assistance, meaning, support with that child should there be an emergency, plans for handling emergencies, medical supports, taking the child to the doctor, to therapy appointments, providing necessary follow-up to that in the home, follow-up to any counseling, behavior, or therapeutic interventions. That doesn't mean the provider is a behaviorist. It means say a foster care home provider might take the youth to see their behavior specialist. The behavior specialist writes the plan. The provider is going to help implement that plan on a daily basis. Okay. So our habilitation provider types. So I'm going to first talk about the physical environment, and then I'm going to talk about the service agencies. So for a physical environment where a child can live outside of the family home, is going to be the same, or is the same, excuse me, for a child who is in child welfare and a child who's not in child welfare, essentially. We'll talk about a couple nuances. When we first started this project to expand the waiver, healthcare policy and financing didn't really have a regulatory structure or method to have a residential setting available for children, really didn't have the oversight, didn't have any of that. All of our residential stuff is really geared towards adults. And so we actually partnered with the Colorado Department of Human Services because they do have that regulatory and oversight structure for out-of-home placements for children and youth. So where we're at right now is we do require any setting is a setting that is essentially a child welfare setting. So for the physical setting, it could be a certified foster care home, could be a group home / group, specialized group facility, could be a kinship home, or could be a residential child care facility. Now, the overseeing agency for a foster care home, or group specialized facility, kinship home, would either need to be a child placement agency, or we do allow the option of what we call a Medicaid enrolled provider. So for our developmental disabilities waiver, we have program-approved service agencies who are approved to provide host home services for adults on the DD waiver. We recognize that those host homes might be uniquely positioned to serve kids as a foster care home as well. So but we also know that a lot of our PASAs, the program-approved service agencies, either are not child placement agencies, some are, but the majority are not, and maybe don't want to go down that path of becoming a child placement agency. So we wanted to find a place to bridge that gap, if you will, that if we had PASAs who had host homes who wanted to be providers, how could we make that work? And so a solution was proposed to us by Foothills Gateway in Larimer County, and they said, what if the county actually worked with the PASA, the County Department of Human Services, and the county certified the foster care home? And after a lot of review, we said, sure, we'll put that option in for provider qualifications. That doesn't mean that every county is wanting to do this or has to do this. Right now, it's mainly, we see that Larimer County is willing to partner in this way, and Denver County is as well. So right now, for the majority of our residential agencies for CHRP, they are child placement agencies. We do have a few PASAs who have entered into some agreements with their local county Department of Human Services. Okay, so let's see. I'm going to go to a couple questions that I think will make sense to address on this slide, and then come back to a couple other ones. So a question from Sarah. To clarify, a host home does have to become licensed as a foster home in order to serve CHRP kids. Yes, Sarah, that is correct at this point. We're going to get into this, and when we talk about the ongoing evaluation and efforts, we are in progress of allowing a host home to be a provider type or be a provider for youth age 18 to 20 in the CHRP waiver without having to be certified. So that's pending a rule change. So if that rule change goes through, that will be effective November 30th. So at this point in time, a host home would have to be certified as a foster care home, regardless of the age of the youth. Starting November 30th, they don't have to be if the youth is age 18 to 20. Okay, another question from Charles. Just so that I am correct, you must be a foster care provider to be able to serve an individual under CHRP services. The actual party providing the service needs to be that. So for a foster care home, or for a foster care home must be certified, kinship home must be certified, a group home, or special, or the words just completely escaped my mind. Specialized group facility. Those RCCF all have to have either their certification or their license under child welfare. I hope that makes sense. And we do allow, like I said, a Medicaid enrolled provider who's not a CPA to pay a foster care home provider for CHRP services as long as that foster care home provider is certified by the county. I hope that helps. Okay. We had a question, and I think this might get into the next slide here. Question about rates. There's a question of a client from Jody. If a client has multiple services, does an agency get paid a flat rate, or is that what creates the level? So at the beginning of the presentation, we did talk about the ICAP. So the ICAP will result in the support level 1 through 5, and then 6 if a 6 is requested, which is a set rate of reimbursement. It's a per diem rate. So the agency bills us. We pay them a daily rate. Of that daily rate, it's up to the agency, the CPA or the oversight agency, to determine how much of that they pay the foster care provider. Unlike child welfare, we don't separate out administrative costs. It's all inclusive in our rate. So the provider needs to negotiate, I guess, with the foster care provider about what percent of the per diem they pay the foster care provider, and then what they maintain for their agency oversight and administrative activities. And then each other service, as we go through each other service in the CHRP waiver has a set reimbursement rate, which is separate than habilitation. All right. Capacity limits. So we had a couple questions about capacity limits. So here they are. So first we'll just talk about total children. So you can see there that really the maximum is 3. If it's going to be 3, and this is children only, 3 children who are all participants in the CHRP waiver, that does require approval from the Colorado Department of Human Services and Healthcare Policy and Financing. And that's even if even if those children are not in child welfare. And I'll explain that in a minute, because we do reference back and use the Colorado Department of Human Services rules. So requests would need to be made for 3 total children in CHRP living in the home, but here's the other maximum: 1 CHRP participant, 2 not in CHRP, or 2 participants in CHRP, no other kids, and then 3 requires approval. So, and I'm going to talk about adults, and I'm going to come back to the siblings group question. So, and I might also ask Nancy to pipe in too with your perspective on this. So then adults, so we can really only regulate, right, CHRP participants and adult DD and SLS waiver participants. So what we have for that mix is, again, a total of 3. None of this requires approval, and 3 cannot be exceeded. So it could either be 1 participant in the CHRP waiver and 2 adults, or 2 participants, 1 adult. Again, maximum of 3 that cannot be exceeded and does not require approval. With sibling groups, we definitely appreciate the value in keeping sibling groups together, and so that will definitely be, we definitely would want to and encourage that wherever possible. Nancy, is there anything you'd like to add on capacity limits for foster care home?
No, I think you covered it well, Michelle. I know a lot of questions do come up about sibling groups, and I think going back to the county to actually talk about that, because you can have, oh my gosh, I'm sure as many of you well know, you could have 5 siblings that want to stay together, plus you have other folks. So a provider is looking at that and going, okay, do we count this as 5? Do we count it as 1? What do we count it? And that actually does go back to child welfare rules. So I would encourage any provider that has those questions certainly to ask them that. But I can say that if you've got a sibling group with a couple, couple may have disabilities, then yes, we would be interested to see what that whole household would look like. And so typically what ends up happening is an appeal goes into CDHS, and then we also review that with them to look at what that household looks like.
Great. Thank you, Nancy. And I think you nicely answered a question from Kay about clarify who has the final approval. It is a joint decision between the Colorado Department of Human Services and Healthcare Policy Financing. Essentially, the request goes into CDHS, they review, send to us, we review, and issue a joint decision. And then again, Teresa had a question about how do we receive approval for a sibling group. Nancy was right on. You need to go back to the county on that one and talk with them, and they'll reach out to us if there's any concerns where that intersects with CHRP. It can be very difficult, I think, sometimes with every individual situation, and sometimes you just have to look at those individually. Then a question from Kay, would CCB or CPA request that approval? That should come from the CPA. By that I mean who requests approval to exceed the capacity limits or to have 3 participants in CHRP. That should come from the CPA.
Michelle, I just want to add one more thing. I know often kids get placed as an emergency, and sometimes that can certainly kind of upset, the environment as well. So we're constantly wanting to make sure that we have good communication with the county to ensure that all of those kids are well taken care of and their needs are being met.
Excellent point. Thank you, Nancy. Oh, right. So then the next slide is just the capacity limits for group home. Again, with these is the total limits. I don't believe that there's any exception process, but like Nancy said, every situation could be different. So if there are questions, reach out to your county. Okay, so the next service we want to talk about is respite. Do we have any other questions or Kathleen, Nancy, anything else to add on habilitation before we move on?
I don't have anything, Michelle. Just gathering info for FAQs.
Oh, thank you. Okay, thanks, Nancy. I should have made that comment at the beginning too. So we have a CHRP frequently asked questions document for case managers. That's on our website. We are creating one for providers as well. We have a lot of known questions, right, that we've collected over the last year as we've been working with providers, but we're also taking the questions from this webinar as a takeaway to a frequently asked document question or frequently asked questions document, and we will, once we finalize that, we'll send it out through Constant Contact, and because you all registered for today's training, we have your email, so we can send you that follow-up FAQ document when it's finalized as well. Okay, we've got a couple more questions on habilitation. Question from Sarah. Foster parents need additional training to be CHRP homes. What are those trainings? Sarah, I will point to that in a few slides when we get to the rules. I don't have all of that memorized, but I will tell you it's essentially you would follow the Colorado Department of Human Services rules, and they have it spelled out in their rules about the additional training requirements for CHRP foster providers. And we'll get to what that rule number is, or the overall set of regulations here in a few slides. Oh, Cindy, thank you for bringing that question back up. Sorry, are you getting to the question about RCCF rates later? Nope, I will talk about it right now. So when you look on our fee schedule for CHRP, for habilitation, we have two sets of rates. We have the foster care home levels 1 through 6, and then we have group home level 1 through 6. So for group home, it's essentially any group home plus RCCF. We don't have that separated out right now. We do have some good news, which is pretty amazing in light of our very unfortunate budget and economic situation right now, is that we had a budget request that we had put forth prior to COVID to actually separate out and have higher reimbursement rates for RCCS because of the higher level of care. And we're really finding that, you know, we do have some youth. These are a lot of times the kids who are going out of state, but really need that higher level of care that can be provided at an RCCF or multiple staff, and the rates we have just didn't cover it. So we were lucky enough to get those rate increases approved, which is super exciting. Sorry, something popped up, and I keep feel like I get distracted by some squirrels, and I'm just sitting in my own apartment. So we are working on implementing those. What we had to do is we had to do a waiver amendment as well, and so we're putting that forward right now. If that's approved, the new separate RCCF rates will be effective January 1, and we'll update our rate sheet at that time. Quick plug, and I don't think we put a slide in this, but because we're going to have these new rates, and I don't have them available for you today, they're essentially, we're finalizing some things with the rate, including that the top rate for RCCF only is going to be a negotiable rate, and we're finalizing those processes. We're going to be putting out, actually, I probably need to get that done this week, but putting out an invitation to RCCFs across the state to talk with us a little bit, because we don't have a lot of RCCFs who have been CHRP providers. We have a couple, Smith Agency, we have some agencies that are doing that, but we definitely need to look at increasing provider capacity. So we're going to be putting out some information about a call with just RCCS to talk a little bit more about what that rate structure will look like and what supports or training could be needed from healthcare policy and financing or whoever else to help to better position those RCCFs to be able to serve kids with intellectual and developmental disabilities in CHRP. Okay. And so Terry asked a question, can the parents or guardian be trained to be the CHRP provider and receive reimbursement? And Kathleen answered that, but I'll say it on the phone too in case everybody's just on the phone. For habilitation, the family or the parent or legally responsible party cannot be the habilitation provider, and actually can't be the parent or legally responsible party can't be a paid provider for any of these services. Now I know there's some exceptions due to COVID and some things that have been allowed for like parents to provide SCC. So when we're talking here, this is just in general, when all those exceptions go away. But definitely for habilitation, we did not make that exception for COVID. We did add that family members who are defined as family related by blood or marriage, they can be paid providers for residential. They could do that under kinship. They could do supported community connections, respite, and what am I missing? supported community connections and respite. So those three services. All right, I'm going to move on to respite, and we'll catch up with any other questions that come in. So respite is much like respite, well, the exact same as respite in our other waivers. It's for the short-term relief of the primary caregiver. Physically can be provided in the family home, in the community, foster care home, group home, or RCCF. So that means that if a child is living in the family home, an agency could send trained staff into the family home. Obviously, things look a little bit different these days, but that is allowable. So they could go into the family home, take the child out in the community. A foster care home could provide respite. A group home or RCCF could also provide respite. Now, we note that obviously the foster care home or group home would have to be certified or licensed. The one thing that's different about respite in CHRP as opposed to CES is we've got service limits for CHRP. So the service is limited to not more than 7 consecutive days per month and not to exceed 28 calendar days per year. One other thing we like to point out with that is that our respite, you can either bill respite in 15-minute unit increments up to 10 hours, and then after 10 hours it's a per diem. But even if you bill, say, one 15-minute unit of respite in a day, that counts as a day to the overall 7 consecutive day limit or 28 days per calendar year. So the message there is if you're going to use respite, you really want to maximize the respite you use in the day. Obviously, we're not going to force respite on families that they don't need, but it's just something important to know when you're working with families on that. Respite is not available to essentially in this form available to a foster care home provider or group home provider because respite may not be billed on the same day as habilitation services. So essentially, if you're working with a foster care provider who needs a break, right, and they need respite, certainly. But what needs to happen there is that the agency would take a look at the per diem rate that they're paying the foster care provider, and then they would have to figure out how they would provide it out of that per diem rate, pay a respite provider. And I think for agencies who operate DD residential services, that's really the same idea, right? Like the host home provider is going to take a day off, then either the host home provider, maybe some agencies do this where the host home provider would just pay the respite provider, or the agency would pay the respite provider and deduct that from the host home provider's payment. Would be the same thing for foster care. Okay, so I want to pause with the questions here. I think Kathleen, again, is doing a good job of addressing them. I'm just going to go back and read them. The question from Natasha, I saw somewhere that in the waiver that a request exception can be made for additional respite time per year. CES has a different respite rule, so family home switching waivers for CHRP for more intensive in-home services are asking about respite rules in order to ensure they're able to maintain placement in their family home. There is not an exception process for respite in CHRP, unfortunately. These limits are the set limits, and we do understand that does present an issue because respite is very important and key in supporting children to stay in their family home. So that's one of the things that we'll look at ongoing. But there's not an exception process. Natasha, where you might be referencing is there is an exception process for supported community connections, which we'll get to in a minute. Question from Elizabeth, can a child get the habilitation rate if they are also getting a CNA? Our answer typically to that is no, because much like the DD waiver residential, typical services, bathing, dressing, that type of thing that are provided by a CPA should be provided under habilitation by the foster home provider. Where we do allow use of dual services would be like for LPN, licensed practical nurse, a registered nurse, maybe who needs to come in and do something like wound care. That's a little bit above and beyond the habilitation service. So what I would suggest is to work with your case manager to work through those individual questions about where there's overlap and where there's not. Question from Sarah, how can we use natural family supports to provide respite? In child welfare, family can be approved for respite if background check, training, and a relationship with a child exists. We are struggling with this in regards to CHRP. Sarah, I think I did already cover this, but yes, you can use family for respite. In fact, we're hoping that where that makes sense, that could really build provider capacity as well. So much like you said here, if a family member is used to provide respite in CHRP, they would need to meet all the training requirements, same ones that you're referencing, and would need to obviously work through an agency, but we encourage family as well. Question from Elizabeth, is respite only for behavior kids and can medical kids get it as well? So anyone who is enrolled in the CHRP waiver, whether that's for complex medical needs or behavior needs, could access respite. All right. And question from Terry, does respite include performing enhanced homemaker services like in the CES waiver? Not really familiar that that's correct for CES, but what I will say is it's pretty broad. I don't think you would use respite for enhanced homemaker, but you know, if a staff is in the family home providing respite for, say, 4 hours through lunch, likely maybe the staff will help, the child eat lunch, might put the dishes in the dishwasher, that would be fine. But I don't think that it would be used for enhanced homemaker, and we don't have homemaker in the CHRP waiver. Okay, question from Leonide. I'm messing that name. How much training would I have to go through to become a provider, and where can I get it? We will get to those slides a little further in the presentation. Another question from Sarah. So a natural family support can provide overnight respite as long as they have the appropriate training. I just want to clarify that CCB has told us differently. Oh, so now I'm reading that differently. So a natural family support, we would technically view as someone who, from our perspective, so just from CHRP, a child who is not in child welfare, but say they use CHRP for respite, supported community connections, wraparound, they live in the family home, but they want to go, aunt, who is a natural support, but not going to be paid, the child wants to go stay at aunt's house for the night, yeah, we have no business with that. That's none of our business. The only time we would have concern, or not concern, but input on that is if aunt was going to be paid for that overnight respite, then we would want to make sure that she was with an agency and met all the appropriate trainings. Clarify if a child is in child welfare, I defer that question to child welfare because they do have some different requirements, I believe, depending on the situation. All right, this is great. Really great questions, everyone. I appreciate it. This is good discussion. So respite provider types. It's pretty straightforward. A child placement agency could have staff, either if they chose to have staff trained to go provide respite, they could do it in a certified foster care home, or our PASAs, who for purposes of today's presentation, the program approved service agencies, we refer to as Medicaid enrolled providers. They can provide respite just like they do in CES, but they would have to be approved to provide respite in CES as well. And then I would want to clarify too that if it's going to be, put aside natural supports, but if it's going to be in like a 24-hour out-of-home respite, that setting would need to be child welfare setting, so foster care home, group home, RCCS. All right, any questions on respite, or Nancy or Kathleen, anything to add?
No, I'm good, Michelle.
I don't have anything either.
Awesome, thanks. All right, moving on. So supported community connections. So supported community connections for CHRP does vary a bit from maybe supported community connections that you're used to with the supported living services or developmental disabilities waiver. So the purpose of supported community connections as it pertains to CHRP is that it's really for behavior support in the community. So it's one-on-one support to deliver instruction or support with a significant behavior need so that that youth can participate in whatever community activity that they want to enjoy. So they would need to be in a community where the child or youth interacts with people without disabilities. Typically there's a behavior plan, like you work with the behaviorist will write a plan about, okay, so if we want to do, I'm going to use bowling. On one hand, it's like, I feel like the worst example there could be, but it's also easy for visualization. But maybe there's a behavior support plan, and the staff would go with the child to the bowling alley, or maybe to a group outside school activity, whatever, and work outside of school. This isn't supplanting anything that should be provided by school. I mean, maybe like peers get together after school for a pool party or something. Then they would have support based on that behavior plan to support that child to manage or maintain behavior so that they can enjoy the activities they want to do. The service is limited to 5 hours a week. However, here's where that exception comes in that Natasha was talking about, that currently we do allow requests to be made to the department. So this one just comes to us. This just comes to healthcare policy and financing. But we do have a process that you can make that request and request more than 5 hours a week. The overall service wouldn't be approved at any more than 260 units per service plan year, which is the equivalent of 5 hours per week. But we can make that exception. Those exception requests go to Kira Acuna, and we have her contact information at the end. We have a contact list at the end of the slide. But realizing that that's a lot to go through, and really maybe unnecessarily, to be able to meet the needs of the families and to have some flexibility to maybe have some more supported community connection when school's not in session, like over the holidays, a little less when school is. So we are changing that as well. So we have a rule change progressing right now to change the weekly unit limit to an annual service plan limit of 260 units. So if that goes through, then, which we anticipate that it will, that will be effective November 30th. So then there will be no exception process. You could just families can choose to use those units how best fits their need throughout the service plan year. And if any of you look at the waiver, you might note that that's already in the current approved waiver. We have to, in some cases, if we have a waiver amendment, well, in all cases, if we do a waiver amendment, we get a change, we have to check rule, and those two things have to be in alignment. And so if the change from the waiver amendment is in the rules, then we can't implement the waiver change until the rule is changed as well. So that's why if you happen to notice that limit right now isn't in the actual waiver document, it's true, but we just can't implement until the rule. Okay, provider types. Also, I should mention that we are also changing the name of the service to Community Connector, and that is pending the rule change this fall as well. And then this can be provided by Child Placement Agency or a Medicaid enrolled provider, aka PASA, who is also approved to provide Community Connector in the CES waiver. And I said this at the beginning of this section. I also encourage you to go through and look at not only the rules, which we'll point to here in a minute, but also the waiver in its full glory, because it does have some additional, like for the staff, like they have to be 18 years of age, here's the training they have to have. So definitely make sure that you're familiar with the provider qualifications section of the waiver for all the details about some of the different trainings and things that people may need. All right. I think that's pretty straightforward. forward. I'm going to move on to the professional therapies. So we have massage therapy, movement therapy, and hippotherapy in the CHRP waiver, just like we do the CES waiver. We've worked to really, I think we had a couple of nuances maybe with alignment that we might still be working on, but essentially these services are available in the waiver. We have recently grown quite significantly because we did some outreach to providers. We have a lot more massage and movement therapy providers for CHRP. So if you haven't looked at if you do know about our CHRP list, and I think we'll have a link to our provider list here shortly. It's just been growing and growing, which is great. So at the beginning, I think we didn't have any or maybe one, and now we have quite a few. So we're really hoping that families and youth will take a look at the service array available in CHRP and use the services that make sense when it makes sense from them, and feel comfortable to move between services, right? And I think we were going to mention this in the habilitation piece, but things can really be fluid. Things are going to change for families and for youth and their needs, and that there is nothing stopping an agency or a family from saying changing services as the child grows. I mean, maybe massage or movement therapy isn't helpful at one age, and then maybe it's helpful at another age. Habilitation, maybe, one of our goals, of course, is to support families to stay together. Maybe habilitation is just needed for short term, right? Maybe it's needed for the family to have a breather, and the child maybe to have a breather from the family, work on some behavior therapies, maybe work on some things, and then transition back to the home. Maybe in some cases it's more long-term because things have really gotten beyond the ability of the family to safely manage, and it's, they're still going to stay involved, but maybe this is the best situation. So every situation is going to be different, but we really work with case managers to try to talk with them about really offering the array of services and supporting families to maybe build a lot of services around them to support that family to stay together. So they're getting respite, they're getting supportive community connections, getting massage therapy if the child qualifies for that. So I won't go over all the requirements of massage therapy, but you can see here this is important to note that it must be a treatment strategy identified for medical or behavioral needs, recommended or prescribed by a therapist or physician. It's important to note that you can't go to massage envy and bill Medicaid. It's got to be a treatment strategy. Hippotherapy. So again, hippotherapy must be a treatment strategy identified for behavior and medical needs. This is not equine therapy, so anybody who's kind of talked about that in CHRP, CES, know that this isn't equine therapy. This is using the movement of the horse for therapeutic means. We don't have a big growth in hippotherapy providers at this point, just FYI. I think I was contacted by another hippotherapy provider, and hopefully we're setting up a call this week. I think there's still some logistical or clinical, what's the right word, professional considerations that we need to talk about with the way we offer hippotherapy and what hippotherapy therapists are really certified to do. So we're still working on that, but again, we do have this. Something else I should mention too is for CES and SLS waiver, we do allow these providers, massage therapists, hippotherapists, and movement therapists to essentially bill through the CCB. So we've kind of historically said you don't have to be a Medicaid provider. You can do a contract or whatever with the community center board, provide the service. The therapist bills the CCB bills HCPF, and then HCPF pays the CCB pays the therapist. We don't have that option in CHRP. So for CHRP, we do require that the therapists or their agency or company become enrolled providers, and then they bill us directly and we pay them directly. Okay, Carrie, I see your hand is raised. I'm going to come right back to that. I am going to just quick wrap up this with movement therapy, and then we'll go to questions. So movement therapy, again, it's must be a treatment strategy for an identified medical or behavior need, recommended or prescribed by a therapist or physician. So just wanted to make those points. So I see that Carrie over, you have your hand raised. Carrie, do you want to unmute to ask your question?
I'm so
And you would do
sorry,
that by
Jennifer.
pressing star six?
I'm just trying to figure out how to get on without keeping, I'm getting kicked off like every 3 minutes. So sorry, I hit the wrong button.
No problem.
Okay, I'm sorry.
Okay. There was a comment in the chat box. Recommendation is to increase the supported community connections to 24 hours a week to match the DD waiver. A lot of us PASAs need to get these younger adults out into the community. Thank you for that, Terry. You know, we're kind of where we're at with that, but there's also to consider a lot of the young adults should probably have some alternate programming with school, even through age 18 to 20, that might fit, be doing some of that. So it's a little bit of a balance between what the school district is providing and what we're providing, but we definitely will take that feedback back, and we appreciate that. Okay, well, we weren't sure if we were going to go a full 2 hours, but I think we're going to. So I'm going to move us forward to talk about our intensive support service. So our intensive support service essentially it has two parts. You'll see on the slide here that I say there are 3 service components. There's 3 billing service components, but the service is either provided in one of 2 ways. One is we have a wraparound facilitator. And a wraparound facilitator develops a plan, does monitoring, works with the family on implementation of that plan. The other part of this service, hope I didn't fade out, I was gesturing with my hands and I think moved the phone away from my face. The other part of this service that could be provided is what we call in-home services. We're actually changing that to child and youth mentorship, and you'll see that in our future slides. So the 2 parts of intensive support can either be used together or separate. You could use a wraparound facilitator, but you don't use child and youth mentorship. You could use child youth mentorship without a wraparound facilitator. And we're going to talk in the upcoming slides a little bit more about wraparound facilitator, what that means, and what child and youth mentorship means. But essentially, this service is that intensive support is really designed to support the child to maintain a stable environment, or develop a plan in a crisis situation, or hopefully prior to a crisis situation, to keep the child in the family home. That could also be if they're in a foster care home or group setting that's really been identified as that this is successful for them, and we would need a wraparound facilitator to keep them in this foster care home. It could be used there as well, because then in that case sometimes the foster care home becomes sort of the family home. Transition support is the same, that has the same 2 components as intensive supports, but it's just used in a different circumstance. So transition support has the wraparound facilitator, and it has the child and youth mentor, which again can use both, or can use either, or can use none, as I think there was a comment, or maybe somebody was using wraparound and not habilitation, or habilitation and not wraparound. Anyway, if those 2 parts are used under transition support, it's used with the goal of transitioning the child or youth back to the family home, or a step down, maybe from a RCCF to a group home, or RCCF to a foster care home, to a lesser setting, lesser restrictive setting, I guess. The reason we did it that way, and I know that it gets a little confusing for people, is we really wanted to be able to try to collect some data on the different ways that wraparound can be used, and the different way that mentorship can be used in these 2 different areas, to stay in the family home or transition back to the family home, or whatever is going to be the best place for that child to live. So that we would have some data to try to measure some outcomes of these services, because both of these, well, we do have mentorship in the SLS waiver, but the wraparound facilitator is a different service, and we don't have that in any other waivers at this time. So now I want to talk a little bit about wraparound, and then we have a slide on child and youth mentorship. We have another slide on this, I guess I'll pause on that. But essentially, a wraparound facilitator is a specially trained person. So they had to have gone through some type of wraparound facilitator credentialing or certification, and we'll get to that, what that means here in a minute. But that wraparound facilitator is really above and beyond case management. I think there was a question earlier, like really what's the difference? So a case manager does things like they do the 100.2, they do the ICAP assessment, they authorize services, and they monitor services in the service plan. And case managers do a lot of other stuff too, but those are kind of the core components, right? A wraparound facilitator has someone who's completed this pretty intense training program and really provides an individualized approach to work with children and their families to bring everything together. So, and case managers do this to some extent, but this wraparound facilitator would really be working with the family and the relevant people in that family's life to pull together a plan with either the goal of maintaining stability, achieving stability during crisis, like in intensive support, staying in the family home, or a plan focused on how do we get back to the family home. And so the wraparound facilitator would really work with the professionals around the table, coordinate between the professionals. An example I use a lot is, maybe they would be looking at a behavior plan written by a behavior therapist, then looking at maybe how that behavior is being supported at school and be like, well, wait a second, these two things aren't in alignment, and then reaching out to those providers to try to get those things in alignment. The wraparound facilitator could be working with the family, and then with the family's permission, maybe they reach out to the case manager to say, hey, I was talking to mom and dad, and they're really thinking that maybe they could use some supported community connection. So it's also just helping get all the necessary pieces in place to support the child and family towards the goal that they're working for. So again, here's the wraparound plan. I'm not going to read this to you, but we have some very specific things that we require, and you'll see that in the waiver and rule that are included in that wraparound plan. And I'm going to come back, we're going to come back to the training and a few more things about wraparound facilitator here in just in a second. The in-home support component, which we're changing to child and youth mentorship, which I wish we would have titled from the beginning. I don't know where we landed with in-home support, but the child and youth mentorship. So what this is that it basically is a staff, and we'll get into the training requirements, but it's like, envision it as like a DSP who has completed some additional training, and we have a slide coming up with what that additional training is, that comes in and works with the youth on kind of what their life goals are. The definition is pretty broad, and it can really be up to the youth and their family or recommendations from other professionals about things to work on. So it could be the implementation of therapeutic or behavioral support plans, building life skills, assistance with advocacy, maybe, I don't know, some supports on how they might want to participate on student council. I mean, I don't know, I think that it's pretty broad. Again, this is the way we have this here is a little bit different than CES, and we're really hopeful that this service could be used to help youth gain life skills. I think a lot of times with children with high behavior needs and medical needs, all the focus becomes on that, and maybe they're not, learning something about how to engage, or maybe learning how to talk to a girl or talk to a boy, or ask someone on a date, or hey, if you want to ask someone to prom, you're probably going to want to start showering. Just those stuff that can help enhance life as well, and then not everything's always about the behavior. So the provider types, so these are the agencies that could hire staff and make sure those staff are trained to provide either wraparound or child and youth mentorship. So it could be a child placement agency, it could be a Medicaid enrolled provider, or RCCF. And essentially, those agencies would need to make sure if they have staff who are acting as a wraparound facilitator and billing, or billing and providing child and youth mentorship, that those staff meet specific specific requirements. So for the wraparound facilitator, we require, the requirements for the education and background is very similar to actually a case manager. So they have to have that bachelor's degree or mix of related experience, and they have to complete sorry, I was just reading the slide. I'm not sure about the biannually. They have to complete certification in a wraparound training program. Now, we do not require one specific wraparound training program. There are several different ones out there. We've included some links on the slide to some that agencies can consider. But essentially what we say is that, you know, once you have a staff trained to provide wraparound, then you would submit that training documentation to us, and then we could approve you as an agency to start providing wraparound. And then as you train new wraparound facilitators, you would just need to maintain record of the training and certification of the new facilitators. So for, I think, several of the wraparound programs, it's kind of a two-step process, most specifically for high fidelity wraparound, which is the coactcolorado.org link there. The way the training is done for the wraparound facilitators, it's a 4 full-day training. And then at that point, the wraparound facilitator gets a training certificate of completion. At that point, then they have to become certified as a wraparound facilitator. They actually have to complete X amount of hours providing wraparound services under the mentorship, if you will, of a wraparound coach. So what we allow for CHRP is that as soon as that provider has completed that training certificate, the 4-day training, that can upload that training for us, and then we can say, all right, yeah, go ahead and start, and by upload I mean in provider enrollment, and we'll your provider, Medicaid provider account. Could start providing CHRP wraparound and billing for CHRP wraparound while that wraparound facilitator is obtaining their final certification. And then once they obtain that certification, at least for your initial facilitator, you would upload that final certification. We did it that way because there had to be a way to pay an agency to start providing the service they needed to in order to obtain the appropriate credentialing. And because the wraparound facilitator is providing wraparound with a certified coach, felt like that still was with the intent of the provider qualification. Additionally, sorry if I'm flipping forward too fast here. Additionally, there are some components. I thought we had a slide on this. Oh, it's in the notes. There are, after talking with stakeholders also really wanted to make sure that a wraparound facilitator, that whatever training course they did really incorporated certain themes and things that they felt would be important to working with children and families who are really high needs, maybe infrequent crisis situations. So there are some training components that these are all listed out in the waiver. We couldn't put them on one slide. It was just going to be too much. So you can look at these in the waiver document itself. But the training program must have some components of things like trauma-informed care, youth mental health first aid, crisis support planning, positive behavior supports, cultural and linguistic competency, those type of things, training specific to intellectual and developmental disabilities. So what we've said is that, there's a list of about, I think, 16 facets to the training we would like to see, that if it's not included in the wraparound training, that the agency can just provide it to their wraparound facilitator themselves. An example of this is we do, one of the little training requirements is training on prevention, detection, and reporting of mistreatment, abuse, neglect, and exploitation. That may or may not be a part of a wraparound training, but most agencies already have that training anyway, right? Like you have your training to notify internally, notify the police and CPS or APS if it's an adult, and then your notification to the case manager. Okay. All right. Then for child and youth mentorship, the direct support professional, so they don't have to have a certification, but we do expect that they complete at least 40 hours of training in crisis prevention, de-escalation, and intervention. And so we do have a list of, again, developed with stakeholders on what exactly those things should incorporate. So again, it's things like trauma-informed care, youth mental health first aid, positive behavior intervention, training on substance abuse, training on intellectual and developmental disabilities, reporting of mistreatment, those type of things. So that can be found in the waiver. And what we don't have any specific courses for that, and really a lot of agencies and CPAs probably already have all of that built in their training curriculum either for staff or for other providers, so that as long as you maintain documentation that you provided training, whether it's your own training or you obtain outside training that meets those topics. And again, we didn't do a slide because it was it was too much. Okay, so I'm going to go to questions, but before I do, we do have a slide a little bit later on with an invitation. So as it pertains to particularly wraparounds, I think what we found in the last year is that while we do have several providers who have met the qualifications and have been approved, we have a couple agencies that are actually out there doing wraparound for CHRP, have heard some early success stories, which is wonderful. I think sometimes it's still hard for families and case managers to wrap their head around wraparound, no pun intended. But I think it's just sometimes it's a little bit new concept, and you're like, well, I've got a array care coordinator, and I've got a case manager, but then what's this wraparound, and what benefit is this really going to give me as a family as I decide if I want this service? And we've heard some feedback, too, from both providers and case managers that sometimes like they know what it is, but it's hard to articulate to the families. And so we have a slide on this, and we'll invite anyone who's interested. We're doing a little deeper dive into wraparound on Wednesday, actually. It's from 3 to 4. We're actually starting monthly CHRP community of practice calls to be able to have some time to delve into either problem areas, where we need more information, how we can share best practices, that type of thing. So our first one is this Wednesday from 3 to 4. We do have a slide on it here shortly with information about how to join. And if you're interested in joining those meetings on a regular basis, please email me or Kathleen or Nancy, and we will add you to the list. But so today, we'll be running out of time to get a lot more in detail on wraparound, but if you're interested, please attend Wednesday. We're going to try to record it and post it as well, and send it out to folks in case you can't make it. We will have guest speaker, Dr. Ashley Brooke-Baca, with the Colorado Department of Human Services, COACT, who can speak much more eloquently and educatedly about wraparound. So. Questions. Okay, so I think, again, Kathleen's been doing a great job. There's a question from Terry. Applied behavioral analysis is one of the leading therapeutic interventions. Is it covered? I think Kathleen got to this in a comment, but it is not covered through the waiver, but it is through our state plan, Health First Colorado, or EPSDT, which is early periodic screening, detection. I don't know, I'm screwing that up. Diagnostic testing, that's it. But that's a really great point, Terry, because not only do we hope that families will use an array of CHRP services and kind of ebb and flow with what meets their needs, but they're also using all the services available on the state plan side. So behavior services, mental health supports, counseling, physical, things like physical therapy, occupational therapy, if that makes sense, speech therapy, if the child needs that, physical care, like physical medical care as well. Okay, question. All the information covered today is really for the existing providers and really nothing useful to new providers. All right, well, thanks for that feedback. If you want to let us know maybe more specifically what would be helpful if we were to do something like this for new providers. Leonard, I would really appreciate that. Okay. I guess if I'm a brand new provider and do not know the specifics, how do I get trained to become a provider? I think Kathleen addressed that. We are going to get to provider enrollment here in a couple of slides. So we do have that piece. We just haven't gotten to it yet. There was a question from Kay, who provides the coaching for wraparound? That's done by a certified wraparound, trained and certified wraparound coach. And so typically, most of our agencies now, I think, are using the high fidelity wraparound training. And so once the wraparound facilitator has completed the training, then they will typically connect either with Ashley or with the COACT and get us a Okay, yes, we have a slide here shortly on Wednesday's call. We're going to get to the rules here in a second. Okay, so moving on because we are getting close to noon. So here are the rules. So because we are using child welfare settings for our habilitation service, we needed to cross-reference Colorado Department of Human Services rules, right? So basically, they're both sets of rules. So what we have here is our HCPUF rules are at 10.8.508, and then the CDHS rules at 12 CCR 2509-8, and there's a link to the Secretary of State's website where you can find that. And so you can read through. I would maybe start with HCPUF rules. I mean, if you're a CPA, you've got the CDHS stuff down, but start with the HCPUF rules. It's section 8.508, and look through there, and then you'll see where it crosses over and says, like, for example, for requirements surrounding the use of restrictive interventions or something like that. We have a citation to the rules at Colorado Department of Human Services. So that's how I would suggest looking at how the two rules intersect. If you're a child placement agency, like I said, you're already very familiar with those CDHS rules. The federal home and community-based services settings final rule does apply to the CHRP waiver just as it does for other waivers. If there's anyone who is not familiar with the settings rule, I don't know if we have a link to that. Maybe Kathleen can get that really quick. That's some federal requirements that providers have to come into compliance with that ensures that people are living in truly home and community-based settings, have choice, rights aren't unnecessarily modified, that type of thing. So work has been well underway with that, and too much to go into here, but we do have all that information on our website as well as FAQs, recorded trainings, if you're interested more in the final settings rule. But I think it's just important to point out, because we get that question, does it apply to CHRP? And yes, it does. Thank you. Kathleen, you posted it. Okay. Human Rights Committee review. So the only Human Rights Committee, for anyone who's not familiar, the community center boards are contractually required to have human rights committees which review certain things. Like they might review right suspensions, rights modifications, restricted procedures, use of psychotropic meds. For CHRP, the only thing that's required for the Human Rights Committee to review is mistreatment investigations, the outcome of those investigations. And then just like for what we're moving to with the other waivers, if there's a rights modification, the case manager is the one that obtains the informed consent. But for more information on the settings rule and requirements, again, Kathleen posted the link in the chat box. All right, provider enrollment. So we have a couple different options here. So if someone is a currently enrolled Medicaid provider, but let's see, maybe it's just enrolled on the state plan side, So this could apply. A good example might be an RCCF, because we do have RCCF benefit on our state plan side. Maybe that agency has their RCCF enrolled, state plan only, and they wanted to add CHRP. What they will need to do is do a new enrollment, or maybe call it a separate enrollment. And they would add provider type 36, which is for the waiver, and then they would add the CHRP specialty. From that, well, I'm going to go into the next steps, and then I'm going to say what happens after that. If the agency is already a Medicaid HCBS provider, so say you're already a provider for the CES waiver approved, all you would need to do within the Medicaid, within your Medicaid portal account is go in and add specialty 619. For brand new providers, people who are not enrolled as a Medicaid provider at all, you would start the enrollment process from the beginning. Again, then you would use provider type 36 and CHRP specialty 619. There is a ton of information about provider enrollment and all the steps to do. Far too much to get into here. So we have a link to our website. There's information on step-by-step provider enrollment. There's a guide. There's trainings on billing. I believe there's even recorded trainings on going through the provider enrollment process. Our rates, our billing manuals, everything can be found there. It's a lot of information. And we have our contractor, DXC, who is available to answer. You could ask them questions, but they will ask or answer questions and provide that technical guidance as well. Kathleen, Nancy, and I also can help in certain circumstances. We have some other staff within OCL who can help with some provider enrollment, maybe when things get snagged. And so we definitely try to support the providers who are trying to add CHRP to try to make the processes painless as possible and troubleshoot when something doesn't go the right way. So the last thing about provider enrollment that I'll say is kind of a manual process is that, once you've gone through whatever phase of enrollment you need to and you've added the CHRP specialty 619, what happens from there is that we will contact you, either probably Kathleen will contact you and ask what CHRP services you want to be approved to provide. For CHRP, we do not have service specialties yet. For those of you who are HCBS waiver providers, you probably know that you've enrolled as like a day hab provider or personal care, whatever your provider, the service you're providing under that waiver. We don't have that for CHRP. We will be adding it, but for now we just have our workaround. So we'll contact you, ask you what service you want to be approved for CHRP, and then from that point we'll work with you to say, okay, then obtain whatever other documentation we need from you to verify that you could provide that service. So if it's for wraparound, we'll say, you're trying to be a wraparound facilitator, we'll say, okay, send us your training certificate, or if you've already got a certified coach or certified wraparound facilitator, send us that, we'll review and then approve. For something like respite, it could be pretty easy if you say you want to do respite and you're already a CES respite provider and everything else is good, we can approve those pretty quickly. Then once we've approved you, you'll get a letter from HCPF, I think that actually probably comes from DXC, that it's all good in the Medicaid system. And then Kathleen and I, or Kathleen will follow up, one of us will follow up and just confirm like your contact information, what you want listed on the CHRP provider list for when people are referred to you. Okay. I'm going to pause and see if we have any questions on provider enrollment. So Kelly asked a question I'm going to summarize, and I think I said this earlier, but I'll say it again. If you, say for instance, you were approved to be, to provide wraparound services for CHRP. You sent in all your initial stuff, your training, your certification of your staff, but then as you train new staff, you don't need to upload that. You need to maintain that on site then that will be checked during your regular surveys. And I also forgot to mention in the regulatory section about who surveys agencies who are CHRP providers. So we have two. So one would be if you're providing residential services, that is monitored by the Colorado Department of Human Services because, again, we're using all of their types. If you're receiving respite in or providing respite in like a foster care home, 24-hour respite, that would also be monitored by Colorado Department of Human Services. For all of our other services, those are monitored by the Colorado Department of Public Health and Environment through our interagency agreement, the same way that they monitor, all of our other waiver services. CDPHE, the Department of Public Health and Environment, they do not do initial program approval for CHRP. So the first time you would come into contact with them is when whenever your annual survey comes up and say you've already been a DD, SLS, and CES provider, you've added CHRP, they'll just, when they come out, they'll just add CHRP to the survey sample. And the other thing is that obviously we also have the CDPHE settings survey team, so you would come into contact with the settings team there as they're out surveying to the settings rule. Okay, question from Natasha. Do rights modifications apply to CHRP participants who are under age 18, or does it only apply to adults 18 under the CHRP waiver, 18 plus? No, it applies to everybody on the CHRP waiver. So if you look at the rules, we did write into the rules for CHRP that informed consent is required for rights modification. So you'll see in like the rights modification section, we reference a good portion back to the Colorado Department of Human Services, but we also added in our requirements that there must be informed consent. So that's regardless of the age. And obviously that is going to be parent or legally responsible party. Okay, question from Allison. I'm a new CHRP provider for movement therapy. I've not seen any referrals come my way. How are those sent? Who by the CCBs? Okay, thanks, Allison. Great question. Yes, that typically would come from the CCBs, sometimes from advocates. So if you want to, Allison, maybe email me separately, or I can't remember what service agency, without having the CHRP provider list up. It could be that maybe the CCB isn't having any families or kids on the CHRP waiver who want massage movement therapy, or maybe they haven't checked the provider list. So we keep reminding them to check that provider list constantly. I would also suggest if you're a new provider, maybe reach out to the CCBs yourself and just say, hey, I don't know if you noticed, but I was approved to provide CHRP. That might help that as well. All right. Oh gosh, we're running out of time. So I'm going to kind of whip through the last couple slides we have here. This is just to let you know kind of the progress that we've made. We still have a ways to go, but we've increased enrollments over 50%. The majority of new enrollments are kids not involved with child welfare. Our provider list has increased over 50%, and here's a link to the CHRP provider list that's public. And we've had some successes. We've seen some youth who have been able to move back to the state from out-of-home placement using the CHRP waiver rehabilitation services. We've seen some success with wraparound. So we're real thrilled, and we hope that continues. And we're going to continue to look at changes. We're continuing to evaluate our residential provider type to increase provider capacity. We get a lot of feedback that people would like to be able to use host homes for kids under age 18. We're taking a look at that. No promises, but we're taking a look at that. Be looking at utilization and cost benefit analysis, continued stakeholder outreach, and we are also, just so you know, really try to work closely with our sister agencies on efforts to better support families, children, and youth as well. So we participate on various committees with child welfare, county departments of home, human, and social services, so really trying to stay involved with the whole spectrum of things that are going on out there for children and their families. Here's the slide for the CHRP Community of Practice meetings. So again, we do these the fourth Wednesday of the month. Our first one is this Wednesday. It's kind of new. We used to just do them really with the counties and CCBs, and now we're transitioning a little bit to make it more, bring in providers and figure out how to continue to learn from each other. So definitely welcome to join us. Please email us and we can add you to the list. And it could also be one of those things too that you're on the monthly invite, and if someone's you can't make it or the topics aren't interesting, you know, you can skip it. We're going to try to record them and get them posted. But again, this one is wraparound. So if anybody on is really interested in a deeper dive, please join us there. All right, questions. A couple more follow-up. We will be putting together an FAQ. You guys have been super instrumental in helping us build what I hope will be a good FAQ list. We're going to add what you've put into the FAQ. So want to see, just double check. I think some of the latest chats were just people wanting to be added to the invite. Anything that I should read out loud? Oh, there's one from Linda. I had understood that our agency was approved for CHRP Respite and Community Connector and in-home mentorship, but didn't get a letter from DXC. Does that mean we aren't? Special kids and special families. Yeah, Kathleen said she'll look into that. That's odd. Well, you know what? This may be too in the weeds. I think Special Kids, Special Families was already a CHRP provider overall, and so you were already approved because you did residential services. You've been a long-time provider for CHRP. Because we don't have in the system the specialty for those services, it's a workaround on our part, and you won't get a letter from DXC that says, hey, you've been approved as wraparound, you've been approved as respite. That's typically going to come from us when we email you to add those to our provider list. So hopefully that helps. Okay. All right. We are over time, but Nancy, Kathleen, anything that you'd like to close with, or anything I major forgot?
Hi, Michelle. I don't have anything to add. This is Kathleen. I included my email in the chat box a couple of different times, and on slide 44, you'll find my email address. There it is. So, sorry about that. That was my toddler. So, if you have any questions, please email me. I'll look into the provider list information, update contact information, as well as reaching back out to everyone about the recording and any other information to tie up.
Excellent. Thank you, Kathleen.
And
Nancy,
Nancy, and I just want to, yeah, this is Nancy. I just want to thank everyone for participating today. A lot of really great questions, and as Kathleen said, our emails are all on the page 44, and if you have any questions, please don't hesitate to contact any of us. Thanks so much.
Okay, well, I think then we can close for today. Thank you all very much for taking the time. Thanks for hanging in there, going a couple minutes over. And please follow up with us with any questions. We're happy to answer those, as both Kathleen and Nancy said, and we appreciate you, those of you who are CHRP providers, everything you're doing, and for those of you considering becoming CHRP providers, reach out to us and we will support you with that and appreciate your interest. So everybody stay happy, healthy, and well, and hopefully we'll talk to a lot of you on Wednesday. Have a great day. Bye-bye.